Morning, you guys. It's Dr. Tochi here. Welcome to another day in my life as a doctor. It is currently the first day of the month and I'm really excited. We are in June and I am working as a hospice and palliative care fellow, and we have 6 more weeks of this fellowship left. So, man, it's surreal. These programs go by really quickly, but today I am at one of the inpatient palliative care services. I'm going to be seeing some consultations. I think the big thing I really want to work on today, and the goal for today, is to get better continuously at symptom management and leading family meetings. So hope it goes well. I'm living in Sacramento right now, and getting closer and closer to the summer. It's getting hotter and hotter and hotter. So I'm really dreading all of that, but I just hope that my body has somewhat acclimated to the temperature out here. I was coming from the Bay Area before and it was much cooler and I took that for granted. So I'm just gonna have to be a little bit more prepared for that. But the biggest thing for me is that I have vacation in about 2 to 3 weeks. So I need a much needed break. I moved my vacation thinking I wouldn't need it, but I definitely felt it the week that I was supposed to be on. So I'm hoping that vacation goes well. I'm gonna be in Cancun. Has the ability to name but not like make medical complex decisions.
Yeah, and that's what your progress notes would say. And he's consistently said this on consecutive days.
And what is the terminology that I'm using?
Designated decision maker.
Oh,
The
so
patient has the
Capacity to name but not to make complex medical decisions.
yeah, and that's what my gut said, but I was like, I don't know, so I didn't really know how to document it. So thank you.
Yeah. Plus, it's like and it's also like fluid. Like just because someone doesn't have capacity, like yesterday, doesn't mean it won't be the same today. Like someone could be altered from like a UTI, but then we clear it and then they get their capacity back.
But we can't move any decision making along unless we designate a decision maker.
I have 4 patients today. I just finished walking through the hospital and seeing all 4 of them. 2 of them I have to go back, and then one of them is actually going to be leaving. I actually saw one of them on Friday, and it was a patient that we are doing a consultation for hospice. So that one is going to be leaving this morning to do home with hospice. I'm happy because I didn't want them to pass here in the hospital, but everything was kind of tied up, so I just went to go stop by the room just to say bye. Family wasn't there, so I just kind of looked in the room. They were sleeping. I don't like to wake up older patients when they're in the hospital in the mornings if there's nothing I really have to do urgently. The other 3 patients, we had 3 new consults. They're all pretty much hospice / goals of care consultations and not really symptom management. One of them is a patient that came in with significant decline, had dementia, and I think they're in the hundreds too. Yeah, 100 years old. So this one's gonna be more or less a hospice discussion / goals of care discussion and trying to see where their kind of goals kind of align. And then the second one is a patient that came in with a devastating neurologic bleed, found down, had hemorrhage in the brain, and has now fixed and dilated pupils as well as no brainstem reflexes. So that's more of a devastating case, and we're going to have a discussion about whether or not to transition our comfort or not. And it seems like the family and the primary doctors are a little bit in a disagreement in terms of the prognostic outlook. So for that one, I come in as a palliative care doctor to kind of see where everybody's heads are at. A lot of times we'll have to mediate the relationship between the primary team and the actual family. So with this one, I kind of want to assess their goals, see what they've been told, and then seeing where the patient's goals were at and what they would have wanted in a situation like this. And one of the big things is that you really want to make sure that patients and families don't do substituted judgment and saying that we should do so-and-so because this is what I would have wanted, instead of talking about what the patient would have wanted themselves. So that's something that's really important that we have to determine whenever we are palliative care doctors, is just make sure that we're putting the patient, family members, or representative in the patient's shoes and saying like, hey, if you think you're able to talk to your family member that's in this situation right now and they're able to communicate with you, what do you think they would say? Not what do you think should happen? So that's when I'm going to be meeting up with the family a little bit later, having a family meeting. And then the other third patient is a patient that it looks like they were on hospice before, and it seems like they've been kind of jumping on and off on hospice. So that one's a little bit more confusing. So I have a second year family medicine resident. We're going to be calling 2 of these families, getting to know them. It seems like we actually have a lot of Alzheimer's patients, so I wasn't able to get too much from these patients themselves. So I'm going to talk with them, and we're going to see exactly what's going on and how to actually progress their care forward. Okay, so we have maybe 2 hours left in this shift so far. I have about 3 to 4 different notes to write. I have officially communicated everything to the attendings and the primary teams. That's one of the things we have to do as consultants, just make sure we close the loop with the entire team. So oftentimes I like speaking directly to them on the phone, because sending a long message that we have for palliative care over the Epic chats or through the chart chats, it's kind of cumbersome. So it's just easy to just talk to them, but sometimes you just gotta have to send those messages. So biggest things I have to go do right now, finish up my notes, maybe do a little bit more education with my resident, and then close the day up. And I have a little bit of studying to do this afternoon for my boards that I have on November 10th for palliative care licensing. So ooh, okay, so I'm finally back home. I am dying right now because it is currently 91 degrees outside, and I need to start looking at the temperature a little bit more frequently, because I do not properly and mentally prepare for it to be this hot. But regardless, it was a really good day today. I am currently back home, left a little bit later. I did a little bit of wrapping up with some patients and their family members in terms of switching them to fully comfort care. And one of the things I wanted to talk about before I end this video is talking about compassionate extubations and what they mean and what they can look like. For example, this patient came in for a devastating head bleed, and they do not have any more brainstem reflexes, such as a cough, a gag. And whenever we see things like that, as well as a fixed dilated pupil, these are all signs that this person has had a severe neurologic devastating injury, and there's no real coming back from that. And the only quality of life that they would have would be getting trached, pegged, and placed into a nursing home. But even for this person, they wouldn't even be able to live in that sort of situation, because they wouldn't be able to trigger their own breaths, and they'd have to be committed to a ventilator. So in terms of compassionate extubations, we do this whenever we are transitioning fully to comfort care, and we say, hey, we've tried to do everything that we can do medically and interventionally, and despite our best efforts, we are not able to get past this medical decompensation. So we are going to do a compassionate extubation. And basically what that looks like is that we take the intubation device out of their throats, and we allow them to naturally pass. There's two different ways you can do that. There's either a weaning off process where we try to slowly withdraw the amount of support that you get from the ventilator and then take it out, or you can just do a complete takeout right in the moment. And the reason why we have two separate ways is because when you have someone with really, really high ventilator settings, you have to try to wean them off, because if you just try to take it out, then they're gonna have a lot of respiratory issues and a lot of respiratory distress. And when we have someone on really high settings, we talk with our intensivist, we talk with, for this case, our neurointensivist, and we talk like, hey, what do you think would be the safest and least traumatizing way to go? Should we try to wean them off the ventilator, or are they on low enough settings where we can just take it out completely? So this person does not have a high ventilator requirement, so this is a patient that we'd actually just take it out and not have to do a whole weaning process. And after we take out the intubation device for the actual compassionate extubation, we actually visually look at them and use some symptom management scales, such as the RDOS, which is the Respiratory Distress Observation Scale. And usually we use that to tell whether or not someone is having respiratory distress. And what we do is that if they have a count that's above 3 or more, then we treat it with some sort of non-pharmacologic or pharmacologic methods. So for this patient, what we would do is that we would take the intubation device out and have a bunch of PRN or IV medications right at the bedside. And if they are having any sort of shortness of breath, then we actually just push IV morphine, IV dilaudid fentanyl to help in that shortness of breath, so they don't feel that breathlessness or have any sort of visual distress, and allow them to pass comfortably. So that's usually what the compassionate extubation looks like. And then after that, we allow the family to be in the room with them for as long as they want. Oftentimes, if a patient comes in for death by neurologic criteria, which essentially means they died by neurologic criteria, like some sort of devastating neurologic injury, as opposed to death by cardiopulmonary criteria, which is you have like some sort of cardiac arrest, and because of that, the body is no longer to function. So a lot of times with death neurologic criteria, you have like the organ donor donation, which is there, which we don't really go and see patients together because it's a conflict of interest. And they go ask the patient and their family member if they're not registered organ donors, if they are interested in doing organ donation. And some families think that their loved ones may have wanted that for themselves. So like so they can actually have pass down some more meaning after they've passed away. But that's not something that is required. You know, they just have to present themselves and say, like, do you think your family member would have wanted to do this? And if no, okay, no problem. Well, no, we're not going to talk anymore again. And then if yes, then oftentimes they can take them to the OR and retrieve some organs to try to donate to people that need organs for organ transplants. But aside all that, today was a pretty fulfilling day. I feel like I was able to be in a position where I was able to do teaching for my resident. She's a second-year resident and was on palliative care for the last week or two, so it's all pretty new to her. So me being able to be in this position, kind of being a mock attending, I was able to kind of do a lot of teaching. And it's not until after, or when you're put in the situation where you have to teach, where you realize how much you know. And that's one of the things that I was kind of wondering about myself, is like, okay, I've been in this program since last year, July. How much have I actually learned? And I was just saying so many different things in terms of information and teaching, which I was like, wow, I actually do know something. But despite all that, it was a good day in the life. I hope you guys enjoyed the video. Comment in the comment section down below what you guys thought about the video, and we'll do another one. Let me know. Peace. Have a nice day.